Well, thank you very much, Mai, and thank you, Anne-Marie, if she's still here, for her very excellent comments. I'm going to talk to you. I'm going to tell you a story, really, and I just want you to reflect on some of the issues which come out of this story as you continue with your own deliberations during the day, and you think of how, in your own organisation, wherever you are, sub-regional, we were talking about Bensdale earlier, regional and metro, small metro, big metro, little metro, private metro, whatever, many different ways of providing chemotherapy. But you think about some of the issues which were raised by the St Vincent's Hospital saga. As Anne-Marie said, safety and quality is in at the moment, and I'll just preface my remarks by saying that the Australian Commission on Safety and Quality in Healthcare is at the suggestion of NSERG, the National Cancer Expert Reference Group, which is a multi-jurisdictional federal government organisation, is going to look into chemotherapy safety and produce a user guide. So if I forget to say at the end, you will all have an opportunity of attending a variety of information sessions or information-seeking sessions, which the Commission will develop and run over the next few months. So this is another real step ahead. So what I'm going to talk about is just one drug, but it's much more than that. I must say one thing at the start is that I'm an old surgeon. I've never given any chemotherapy, and so probably I was a good person to oversight what the St Vincent's Hospital's response to its issues were, because I'm interested in hospital systems. And I think Anne-Marie mentioned systems probably about 10 times in her short presentation. So what we're really on about is getting the right system in place so that patients, wherever they are in Victoria, can be assured of having appropriate and an expert and high quality and safe care. So I was actually privileged, and I think I must say something about St Vincent's Hospital in Sydney. They went through hell, as I'll show you, but they actually faced the situation and they came up with the changes which were required to deal with the issues which were exposed within that. So, although it was just a drug, in fact, it expanded into a sort of a whole process, and I've mentioned a few points there. There was political intervention, there was media excitement. Nothing excites the media more than something to do with cancer and something to do which suggests that people haven't been treated properly. So the Sydney Hospital was one, the Sydney St Vincent's Hospital was one. There's also an issue in South Australia and also an issue in Queensland. So, and probably there's many other issues which haven't come to light. So this is a very, very relevant issue for us. Patient concerns and fears become magnified when people think they haven't had the appropriate treatment. Quality, safety and culture issues, clinic and prescription systems, documentation was a key issue, and I'll come to that, and communication was important. So the story here was about one medical oncologist who gave a dose of carboplatin less than the prescribed dose. Now, he never admitted that he did anything wrong. He actually believed that he was doing the right thing by giving a lower dose. And there was never, to be fair to him, there was never any suggestion that any of the patients had a deleterious effect from that. But the issues were severe for the hospital and for people and for patients because of the concerns and the issues which arose out of that. There is a protocol. We're talking about a protocol over in the table over in that corner over there with my pharmacy friends from Peter McCallum. You'll hear a lot about protocols here, and they are actually a sort of a problem. We believe in protocol-based care, but what is in the protocol? Who wrote the protocol? Is the protocol relevant for your or my group of patients or your or my hospital? It is an issue. It's called evidence-based care, and I think it's actually becoming increasingly complex as we try and really write down or get exposed what evidence-based care is. So in this particular group, these were off-protocol doses of carboplatin, not a mistake, but a deliberate choice on the part of the doctor. So this goes back a long way, and I might add these slides are actually St Vincent's Hospital slides, so I'm not exposing stuff which they don't want exposed, so don't feel that I'm letting secrets out of the bag. This is all in the public domain, and one of the key issues about any safety and quality issues, it has to be in the public. It has to be out there. You cannot hide it away. So this went back about 2005, and the first issue which came was some cultural issues within the chemotherapy or the medical oncology department. And I guess one simple lesson for you to take away is never allow in your setting cultural issues to blind you from making a statement or a move or making a notification which you think is important. And we are all caught up by these cultural issues, a particularly difficult male or a difficult female who's you're frightened of approaching. It's something you have to get over and you have to work through it. So this happened a long time ago. And then there was the incident management system, which is sort of like a Riskman thing, Riskman. Do you like Riskman? I've never found anybody who does like Riskman, but it's what we have. And there were a couple of incidents entered into the Riskman system. This is, again, 2012. There was a bit of a raising of concern about off-protocol prescribing. And then in 2015, a significant person in the hospital, head of radiation, said, look, this is a problem because carboplatin was basically used as a chemosensitizer for radiation. So the radiation people were very involved, as were the surgeons, because head and neck cancer, which is the main area here, literally is a tripartite approach to the management of these people. And then in that time, the Director of Medical Services initiated an internal review. Now, if you think about that, it's a real problem for anybody, and much of this is not of our particular, or even my particular responsibility. But when you have a review within a hospital internally, who do you get to do it? How's it done? It's a complex and difficult issue. And then there was decided they should have an external review. Just to come over to the right side of the slide, it is interesting how one responds to issues such as concerns about problems which might occur within a unit. And I'm just come to the one about escalation to executive. I'm quite interested in this issue of heuristics and what we do to, what informs our decision making. And it's very much based on our own experience in the past or what someone's told us recently about some issue or something. So it's complex to make a move and stand back and say, look, I've got to go in this direction, and not just say, well, look, I actually have known this doctor for many, many years. He's a good person. I can't believe this is going on. These are the issues you have to deal with. The internal review was not well done. And then it went to the media, and then the hospital shared its findings with the internal review with the media. This caused more trouble because the internal review was poor, and then finally an external review was underway. As soon as the media got involved, and of course it hits the headlines all over the place, and some of you may remember some of those headlines. And then the external review was a problem. Who's going to do it? This happened to be at Christmas time. The right person wasn't there. So there are all sorts of issues there about getting the external review done. And finally it was completed, and then it all started to happen. It went to a 7:30 report. Ministry of Health was finally notified, so luckily Anne-Marie's left by now. So she would have been a bit cross to find it took 10 years to get to the Department of Health to tell them this is a problem going on. And then the patients were notified. And just to go again to the patients notified on the right-hand side of this slide, this in itself is a very complex thing. You can imagine if you're in a clinic setting and a patient rocks up and says, I think I've had someone says I've had a diminished dose of chemotherapy, what's the impact for me? How do you respond to that? It was very complex. No one knew how to talk to the patients, no one knew how to reassure the patients. Can you reassure them? Or even understand what should happen about those patients? So it's it just raised complexity after complexity. And then, of course, it all happened. And this is a slide which has got lots of stuff on it. I'm not going to go through it all, but it just indicates the things which happened within the hospital when everybody started to get involved, from the board of management down to the most junior person. It was a very complex and very, very difficult setting. I want again just to sort of make the point is on the right-hand side of these slides, these two boxes here. The ministry wants answers, but where were the answers? This goes back to 2005. They didn't have an electronic medical record. They had bits of paper all over the place, poorly written, no one could decipher it, and sometimes some of this was off-site, done at country hospitals, no one would even find the records. Just basically a mess. So it sort of worked all right for most of the years, and when someone starts to scrutinise it, hey, this is not right, this is not right. And finding the data on these patients back for a number of years was a real problem. And at the end of the day, they had 3 inquiries in New South Wales. One was an inquiry under the Health Services Act. I'm not sure that we have exactly the same act or the ability to have an inquiry in Victoria as New South Wales does, but they had a major inquiry basically from the Department of Health into this issue. Then the politicians there was a real issue about politics in Sydney, so they had a select committee, a political committee looking at this, and then finally this all went to a Health Care Complaints Commission. And just to end up saying that although the St Vincent's Hospital was rebuked, if you like, for allowing this to happen, that basically all the inquiries said, well, their responses have been adequate and good and have improved things. Now, just very briefly to go through these things, we're up for time. I wanted just to sort of say some of the things which came out of this. The first thing, which is probably not really a major issue for those of us in this room, but is an issue for hospitals in general or health services in general, that is the culture issue. I've mentioned that. The second issue is the issue of risk man and how you define the seriousness of an issue which comes out of risk man, whether a person just didn't get their meal last night or whether they've had a serious issue which needs to be properly escalated. Documentation is a big issue. And essentially, towards the bottom of that slide, the issue of implementing proper systems of clinical management and clinical information, and that's, of course, very easy to say, but quite difficult to do. So I don't know how many of you would go to a lot of the quality committees in the cancer space, and if you don't, I think it's an issue about whether the people on the ground get to some of these quality meetings. The St Vincent's Hospital had a mortality and morbidity meeting, which I've always never liked the idea. That is, you review the people who died or something in the previous month, and you sort of say, was that good, bad, or indifferent? And so one of the recommendations was that those meetings should have benchmark data. And that in itself is very, very difficult. That is, if you're talking about a regional area, how do you benchmark what happens in that region compared with another region? But still, these are issues which came out, and it was said that you should have benchmark data about your results so that you can see whether you're in order. So one really important thing which came out was this issue of prescribing chemotherapy. So we have protocols and we have individual patient assessment and individual clinician bias, which says the clinician says, I don't want to use that protocol. I want to make a lower dose or a higher dose or whatever. Okay, that's fine. But it has to be documented in the history. This was never documented. It has to be documented in the history. It has to be explained to the patient. The patient has to possibly include that in some sort of consent form, and it has to be discussed with members of the multidisciplinary team. So my total commitment in life these days is to say that cancer is a multidisciplinary approach, and so if it's not just the clinician has to sign off on it, but the pharmacist has to sign on it, the oncology pharmacist has to sign off on it, if necessary the nurse has to sign off it. And if it's a persistent change, someone says, look, I'm always going to make this difference, then it has to be escalated to a higher level within the oncology department to make sure everybody's happy with that sort of change. I mentioned protocols. Multidisciplinary team meetings are very important. Just skip through this pretty quickly. This is a really important issue, that is, clinicians had to ensure adequate informed consent for all medical interventions, including chemotherapy. So this, I think, does happen nowadays, but it didn't happen 10 years ago. People have to sign in and say, I'm willing to have this chemotherapy, understand the risks, understand the potential outcomes, and this is able to be firstly documented and able to be seen by someone else who wants to do a review or an audit. So the issue of protocols I've already mentioned, and EVIQ I'm sure will come up. EVIQ is the basis a standard which is accepted across Australia, but many people don't use it. But the understanding of how we manage protocols and how we look at variation from protocols is a key issue. So what I would absolutely say, I've already mentioned this, that this is for all... Okay. 1 minute. So this is my real interest in life, is the multidisciplinary care team is absolutely critical for both prescription of treatment and delivery of treatment. And I would suggest to you that you look at the optimal care pathways, which have all this information in them. We're actually doing a refresh of the optimal care pathways, and we will refresh them with the understanding of the chemotherapy issues which are in place at the moment, because quality and safety in chemotherapy delivery is absolutely essential. So with that, I will stop. Thank you very much for your attention.
Given that we've known for many years that it is largely around the culture of an organisation, quality and safety, what do you think are still some of the key barriers around really embedding that culture of quality and safety in organisations?
Well, you mentioned two things. Firstly, there's, if you like, culture, and then there's culture of quality and safety. So I think that there's a real issue still in hospitals in terms of the capacity of people to talk to each other, to understand each other's point of view, to understand each other's problems in hospital life. And how you get over that? Well, the usual thing is to say you bring a consultant in and you have a series of meetings and you have people talking together. I think that's a sort of a one-off solution. But what I think we need to do is absolutely say that there should be good communication between all members of the team, and there should be regular meetings, weekly meetings. I know most of you will have these things, but in those weekly meetings, everybody's got to be encouraged to speak up. Everybody's got to their time in the what's the word, sun, moon, whatever, time in the system, and everybody has to, and I think it's from the doctors right down to the workers, that we all have to be on the same page, and that message has to be out there. It should be up on the wall. We're working as a team. And I think the other thing which happens is that if there is an issue, it has to be well dealt with by the organisation, so that if you have an issue, even if it's not a big issue, then you should be able to expose it and talk to people about it without fear of any concerns.